Bismillahirrahmanirrahim. Assalamu alaikum. Me, Dr. Tayyab, and today my topic of presentation is hypertension and management. First of all, you'll see the prevalence of hypertension in Pakistan. So, according to last population-based National Health Survey of Pakistan, nearly 18.9% people in Pakistan above age 15 years were hypertensive. Classification of blood pressure for adults age 18 years according to recommendation of 7th report Joint National Committee on Prevention, Detection, Evaluation and Treatment of High Blood Pressure. Blood pressure in adults is classified into normal, pre-hypertension, stage 1 and stage 2. For normal, systolic lower than 120 millimeter of mercury, diastolic lower than 80 millimeter of mercury. Pre-hypertension, systolic 120 to 139, diastolic 80 to 89. And stage 1 is systolic 140 to 159, diastolic is 90 to 99 millimeter of mercury. Stage 2 is systolic 160 or higher and diastolic 100 or higher. Classification above is based on average 2 or more readings taken at each of 2 or more visits. 2017 American College of Cardiology, American Heart Association guidelines of classification of blood pressure. In this guideline, they eliminated pre-hypertension classification and classified into two categories. First one is elevated blood pressure with systolic blood pressure between 120 to 129 and diastolic blood pressure less than 80 millimeter of mercury. Stage 1 hypertension, systolic blood pressure 130 to 139 or diastolic blood pressure 80 to 89 millimeter of mercury. Hypertension is further classified into primary and secondary hypertension. For primary hypertension, accounts for 90 to 95% and may develop as a result of environmental or genetic cause. Risk factors includes obesity, family history, age, smoking, increased salt intake, low potassium intake, NSAID therapy, alcohol. Primary hypertension has no single cause but can be associated with many factors. Primary hypertension is incurable but controllable. Frequency surges progressively with obesity and advancing age. Or secondary hypertension could be developed as a result of multiple etiologies. Risk factors include renal disease, adrenal diseases, obstructive sleep apnea, and hyperthyroidism. Polycystic kidney disease, stress, medications that includes NSAID, corticosteroids, decongestants, estrogen, and coction of aorta. So complication of untreated hypertension includes cardiovascular diseases, cerebrovascular disease and dementia, hypertensive kidney disease, aortic dissection, and atherosclerotic complications. Sign and symptoms. Sign includes elevated blood pressure, conjunctival hemorrhages, hypertensive retinopathy, radiofemoral delay because of coction of aorta, loss of peripheral pulses because of atherosclerosis, and aortic regurgitation. Hypertension is also called silent killer as sometimes doesn't show any symptoms. Other symptoms are headache, confusion, visual disturbance, nausea, vomiting, palpitation, epistaxis, etc. International Society of Hypertension Diagnostic Threshold 2020. Currently, we have different points, different places to measure blood pressure and to confirm threshold. For office, clinic or OPD, that is threshold is 140 by 90. For home measurement is 135 by 85. 24 or ambulatory monitoring is 130 by 80, and daytime average ambulatory monitoring is 135 by 85, and nighttime ambulatory 24 hour ambulatory monitoring is 120 by 70. So these are the thresholds of different places to measure the blood pressure. Hypertension Canada guidelines for diagnosis 2018. Sorry. So according to this algorithm, will describe how to diagnose and the hypertension and how to diagnose if patient is not hypertension, and how to say this is a white coat hypertension. So elevated blood pressure reading in office, home, or pharmacy that gives us a reading of more than 180 by 110 millimeter of mercury. If this is then this is hypertension. If reading is less than 180 by 110, then we'll go check for the other risk factor if the patient is diabetic, and automated office blood pressure measurement is more than or equal to 130 by 80, then that is also hypertension. If not diabetic and automated office blood pressure is more than or equal to 135 by 85, or non-automatic office blood pressure measurement is more than or equal to 140 by 90. If less than this, then this is not a hypertension, and if yes, then out of the office measurement, ambulatory blood pressure measurement, daytime mean could be more than or equal to 135 by 85, or 24-hour mean more than 110 130 by 80, or home or other places mean is more than or equal to 135 by 85. So if this is present, then this we could call this a white coat hypertension. Laboratory findings could be the ECG and chest radiographs. ECG to look for left ventricle hypertrophy or other findings, and chest radiographs to see for portion of aorta and other things. Echocardiography, renal ultrasound to rule out polycystic kidney disease, hydronephrosis, renal artery stenosis. 24-hour urinary free cortisol, urinary metnephrines, serum electrolytes, urea and creatinine, blood sugar levels because hypertension is a risk factor for diabetes, plasma lipids, serum uric acid because hyperuricemia is contraindicated to diuretic therapy. Management target goal of blood pressure in hypertensive patient is less than 140 by 90, and in diabetics is less than 130 by 80. Hypertension can be managed by non-pharmacological therapy, by lifestyle modification, and pharmacological therapy. Non-pharmacological therapy includes lifestyle modification, that includes weight loss, aerobic exercises, smoking cessation, decreased sodium intake, uh, less alcohol intake, and DASH diet. That is in DASH diet. Pharmacological therapy for the treatment of for the management of hypertension references similarity, and first line this management is according to uh, age and skin race of patient. So first line in black person of all ages, first line is calcium channel blockers or diuretics, and first line in all other ages less than 55 years is ACE inhibitor or angiotensin receptor blockers, and first line in all other ages more than 55 years is calcium channel blockers or diuretics. Second line in black person all ages is angiotensin receptor blockers or angiotensin converting enzyme inhibitor or vasodilating beta blockers. All other ages less than 55 is vasodilating beta blockers, and all other ages more than 55 years angiotensin receptor blockers or ACE inhibitors or vasodilating beta blockers. For resistant hypertension, in all ages and all races, we will say the aldosterone receptor blockers are the first line. Recommended antihypertensive for coexisting indication. So if a patient already have a coexisting indication, so we'll choose the antihypertensive according to this. If patient is a known case of heart failure, diuretic, beta blocker, ACE inhibitor, ARBs, and aldosterone antagonists are choices. Following MI, beta blocker, ACE inhibitors, and aldosterone antagonists are the choices. High coronary risk, coronary disease risk in diuretics, beta blockers, ACE inhibitors, calcium channel blockers are the choices. For diabetes, diuretics, beta blockers, ACE inhibitor, and ARBs and calcium channel blockers are the choices. Chronic kidney disease is ACE inhibitor and ARBs. Recurrent stroke prevention, we could use diuretics and ACE inhibitors as a choice of antihypertension. Comparison of blood pressure treatment threshold according to guidelines of American College of Cardiology, American Heart Association, Hypertension Canada 2018, and European Society of Cardiology 2018. So according to these guidelines, if the patient is American Heart Association, cardiovascular risk is not increased, then threshold for pharmacotherapy, that means you start a treatment, threshold will be more than 140 by 90, and target will be less than 130 by 80. For hypertension Canada, if there is no cardiovascular risk, then threshold for pharmacology will be more than 160 by 100, and target will be less than 140 by 90. And for European Society of Cardiology, if there is no cardiovascular risk, then threshold will be more than 140 by 90, and target will be all less than 140 by 90. Mostly we say less than 130 by 80. Then we will go for cardiovascular risks. And American Heart Association guidelines, if there is a cardiovascular risk, increased cardiovascular risk, then threshold will be less than 130 by 80, and target will be less than 130 by 80. And for hypertension, Canada, if cardiovascular risk is increased, then threshold for pharmacotherapy will be more than 140 systolic, and target will be less than 120 systolic. And for European Society of Cardiology, if cardiovascular risk is increased, then threshold for pharmacotherapy will be more than 130 by 80, and target will be 120 to 130 by less than 80 diastolic. As hypertensive urgency is defined as systolic blood pressure of more than 220 or diastolic blood pressure of more than 125 with no evidence of target organ damage. In hypertensive urgency, blood pressure should be reduced within few hours. And on the other hand, we have hypertensive emergency, which is defined as systolic blood pressure of more than 220 and diastolic blood pressure of 140 millimeter of mercury with and organ damage. In hypertensive emergency, blood pressure should be aggressively lowered within minutes to an hour by no more than 25%, and then lowered to 160 by 100 in next 2 to 6 hours. Causes of hypertensive emergencies. Most patients who develop hypertensive emergencies have history of inadequate hypertensive treatment or abrupt discontinuation of medication. Other are renal parenchymal diseases, renovascular diseases, endocrine disease, drugs, CNS factors such as trauma, coaction of aorta, eclampsia or preeclampsia. And organ damage due to uncontrolled BP includes a neurologic, that is a hypertensive encephalopathy, cerebral infarction, subarachnoid hemorrhage, intracranial hemorrhage. Cardiovascular is myocardial infarction, acute left ventricle dysfunction, acute pulmonary edema, aortic dissection. Other organ system may affected that may lead to acute renal failure, retinopathy, eclampsia, microangiopathic anemia. Clinical presentation of hypertensive emergencies are cerebral infarction are the mostly presented, that is 24.5%, pulmonary edema 22.5%, hypertensive encephalopathy 16.3%, and congestive heart failure 12%. To evaluate, we'll go for CBC to exclude microangiopathic anemia, toxicology screen, pregnancy test, electrolyte levels, RFTs to evaluate renal impairment, dipstick urinalysis to detect hematuria and proteinuria, chest X-ray for pulmonary edema, ECG, head CT to evaluate neurologic sign or any sign of bleeds. Management of hypertensive emergency. According to new guidelines of 2023, sodium nitroprusside is no longer the treatment of choice for acute hypertensive problems. In most situations, appropriate control of blood pressure is best achieved using combination of nicardipine or clevidipine plus labetalol or ismolol. Management. This management is in descending order of preference. So, management of hypertensive emergency. First, agent will be nicardipine. That belongs to family of calcium channel blockers. Dosage is 5 mg per hour. Intravenously may increase by 1 to 2.5 mg per hour every 15 minutes to 15 mg per hour. Clevidipine, that belongs to family of calcium channel blockers, 1 to 2 mg per hour intravenously initially, double rate every 90 seconds until near goal, then by smaller amount every 5 to 10 minutes to a maximum of 32 mg per hour. Labetalol, that belongs to family of alpha and beta blockers, 20 to 40 mg intravenously every 10 minutes to 300 mg 2 mg per minute infusion. Ismolol belongs to beta blocker, that loading dose of 500 microgram per kg intravenously over 1 minute. Maintenance is 25 to 200 microgram per kg per minute. Phenoldiazepam belongs to dopamine receptor antagonist. Dosage is 0.1 to 1.6 microgram per kg per minute intravenously. Enalaprilat belongs to ACE inhibitor class, 1.25 mg intravenously every 6 hours. Furosemide diuretic, that is diuretic, dosage is 10 to 80 mg orally or intravenously. Hydralazine vasodilator, 5 to 20 mg intravenously, may repeat after 20 minutes. Nitroglycerin, that belongs to vasodilator class, dosage is 0.25 to 5 microgram per kg per minute intravenously, useful primarily with myocardial infarction. Sodium nitroprusside, that belongs to class of vasodilator, 0.25 to 10 microgram per kg per minute intravenously, no longer first line choice. Management of hypertensive urgencies. For hypertensive urgencies, clonidine, that belongs to central sympathetolytic, dose is 0.1 to 0.2 mg orally initially, then 0.1 mg every hour to 0.8 mg orally. Captopril, that belongs to class of ACE inhibitor, 12.5 to 25 mg orally. Nifedipine, that is a calcium channel blocker, 10 mg orally initially, may be repeated after 30 minutes. Treatment of hypertensive emergency depending on primary site of and organ damage. If the patient presented with hypertensive emergency and end organ damage is suspected to be, is confirmed or suspected to be myocardial infarction, then treatment of choice will be nicardipine plus ismolol. That should be avoided in left ventricle dysfunction, or nitroglycerin plus libitalol. For acute kidney injury, phenoldiazepam, nicardipine or clevidipine. Aortic dissection, ismolol plus nicardipine, or ismolol plus clevidipine, or ismolol plus nitroprusside. For acute pulmonary edema or left ventricle dysfunction, nicardipine plus nitroglycerin plus loop diuretics, clevidipine plus nitroglycerin plus loop diuretics. Nitroglycerin is drug of choice in LV dysfunction with ischemia. For ischemic stroke, that where we need to keep the systolic blood pressure more than 180 and the intracerebral hemorrhage for systolic blood pressure more than 140 to 160, nicardipine, clevidipine, and libitalol are the choices. For eclampsia, preeclampsia, libitalol and nicardipine are the choices. When blood pressure has been brought under control, combinations of oral antihypertensive agents can be added as perinatal drugs are tapered off over a period of 2 to 3 days. Thank you, sir.